Well, good evening, everyone. We're going to go ahead and get started with this evening's Journal Club. I'd like to welcome everyone tonight to the Journal Club meeting. My name is Josh Romero. I'm a current sports medicine physician at Mayo Clinic in Rochester, Minnesota. I'm also the Associate Program Director for the Sports Medicine Fellowship out here. I'm currently a team physician for a local junior college, as well as some junior hockey teams here in town, and then as well as a high school. I served as the sports medicine resident council president 3 years ago, and I was fortunate to be part of a great team that helped to develop this journal club several years ago. And I'm really happy and enthusiastic that it's continuing to this day. We have several colleagues on this call tonight that are going to be presenting some articles as well as providing some discussion for us. So without further ado, the goal of the AMSSM Journal Club is to provide a national platform for both student and resident members to present an article from the list of the top 120 articles that every sports medicine fellow should be familiar with. Our intent is to make this a fun learning experience to give medical students and residents mentoring opportunities with other AMSSM members while developing skills of reviewing articles and making PowerPoint presentations. As typical with other presentations, we're going to have 3 presentations tonight. The format for tonight's journal club will be that each presenter will have approximately a 20-minute block of time that includes both a question and answer session after the presentation. I would really encourage everybody on the call to please enter your questions using the chat function or unmute your mic and speak up during the Q&A session. Without further ado, I'll introduce our first presenter tonight. So we have Dr. Raymond Zhou, as well as his club mentor, Dr. John Kiel. Dr. Raymond Zhou is an EM resident at Mount Sinai, Morningside West, by way of medical school at Vanderbilt and college at UCLA. Before residency, he worked as a soccer and swim coach. He is interested in the management of acute injuries through sideline coverage, with a particular interest in traumatic head and brain injuries. He is excited to learn more about the practice of sports medicine through involvement with AMSSM. His presentation is on the article, Invited Review, Sports Eyewear Protective Standards. I'd also like to thank Dr. John Kiel for serving as his club mentor. Dr. Kiel is an associate professor of emergency medicine and sports medicine at the University of South Florida, where he holds a core faculty position in the emergency medicine residency program and helps with team coverage with the USF Bulls, University of Tampa Spartans, Tampa Bay Buccaneers, and Tampa Bay Lightning. In his free time, he enjoys CrossFit and spending time with his family and dogs. At this time, I'd like to welcome Dr. Zhou to please go ahead and take it away with this presentation.
Okay, so hello and welcome to my presentation on protective eyewear. My name is Raymond and I'm an EM resident over at Mount Sinai Morningside West. Thank you for the introduction. My mentor for this presentation was Dr. John Kiel. My learning objectives are as follows. I first want to review traumatic ocular injuries, then review the incidence of ocular injuries in sports. I also want to compare different ocular injuries across sports, review the standards for protective eyewear, and discuss design considerations for protective eyewear. Again, I first wanted to start by giving a broad overview of various eye injuries, while also highlighting the key aspects of presentation and management from the perspective of a physician caring for acute trauma, like myself in the ED. And I took this figure from Netter's Sports Medicine, which provides the following 3 categories. Common injuries include corneal abrasions, which occur when the surface of the eye, the cornea, is essentially scratched. This could be by a fingernail or a foreign body, such as a ball. And so abrasions are often confirmed by fluorescein stain, which demonstrates uptake of dye within the cornea. And this essentially demonstrates damage to the external surface of the eye. And so these patients often complain of blurry vision and eye pain and the sensation of a foreign body on their eye. And in contrast, sometimes a foreign body actually is identified on the eye. And this could be sand or debris or a piece, for example, of a broken ball. And this happens when the foreign body is essentially attained onto the surface of the eye. And it can happen even under the eyelid, in which case this can cause persistent abrasions to the cornea. And classic teaching in the ED, which is very daunting, includes using a large gauge, sometimes 18 gauge needle to remove the foreign body from the cornea if an ophthalmologist isn't available, because this can cause continued worsening damage if not removed. Lacerations are another common thing that we see in the ED. This can happen when the face is hit by a ball or fists or the ground. And this frequently involves the eyebrows, but it becomes more complicated when it involves the eyelids. especially when it involves the lid margin or the medial aspect of the eye. And so when it does involve the medial aspect of the eye, one thing we need to worry about is essentially damage to the lacrimal system, which is of particular importance because it needs to be repaired promptly to restore drainage of tears. And this requires ophthalmology evaluation closely. Hyphema is another disease process, essentially where blood collects in the anterior chamber of the eye. This is anterior to the lens, and this can cause damage to the iris if large and left untreated. And I think one other distinction I quickly want to make here, all of these disease processes that I mentioned are easily identified with gross examination of the eye. They can be done with essentially a blue light and a dye, and they can often be intervened upon in the ED without an ophthalmologist. And so in contrast, diseases that are posterior, let's say in the posterior chamber of the eye, are usually more complex and more difficult to identify. And so one example would be a lens dislocation. Essentially, when a blunt traumatic event causes the lens to move posteriorly, you can see here on this point of care ultrasound behind the iris. And point of care ultrasound is really helpful for these diseases. Another one is vitreous hemorrhage, which and retinal detachment, which sometimes go hand in hand. And again, here is shown as hemorrhage is identified as a echogenic structure or echogenic material within the vitreous. And vitreous hemorrhage can be differentiated from a retinal detachment, which remains tethered to the optic nerve even when it is detached. And so now quickly moving on to the most serious injuries, we first have open globe or globe rupture, which is defined as a full thickness injury to the eye, whether it's the sclera or the cornea. And this can be first diagnosed with an iris prolapse on gross examination, essentially when pieces of the iris are coming out of the hole in the eye, causing this teardrop pupil, as well as a Seidel sign, which is essentially on the fluorescein stain, transparent fluid that is leaking. And that's essentially vitreous or aqueous humor that is draining and causing, again, that linear appearance of fluid. Globe rupture is an ophthalmologic emergency and needs to be evaluated very carefully. For example, I've seen on evaluation when someone's just pushing on the eye extrusion of intraocular contents, and that can cause irreversible vision loss. So you shouldn't be checking eye pressure in these patients. And then the last disease process I want to mention would be essentially fracture of the orbital bones. And this happens due to transient increases in pressure. This can be due to blunt trauma, let's say from a ball hitting the eye. And complications can be extraocular muscle entrapment, which causes limitation in the extraocular movements. And something that's related that I think is important to mention would be retroorbital hematoma, which can cause rapidly increasing pressures within the orbit and then compression of the optic nerve as a result. And it's important to mention because lateral canthotomy is one of the few vision-saving interventions that we can provide in the ED, and that can really save an eye. Okay, so now moving on to the article, the authors wanted to study what percentage of eye injuries are attributable to sports, and they first did so by this literature review of over 20 articles. And so they were very transparent with the limitations. One of them was that there was a lack of specific rates of the different pathologies mentioned in the last slide. Only very few of these articles specified the rate of, let's say, hyphema or open globe or et cetera. And many of the studies that they looked at, but ultimately did not include, grouped head and face as well as neck injuries together, which is obviously a limitation that makes it difficult to study just eye injuries. Another limitation is that investigators often don't know the rate of different sports being played across different countries. And that's something that I'll discuss more in greater detail when I look at the specific figures. Other consistencies that you can see reflected here include the clinical setting, let's say the clinic versus hospital versus insurance data. And some studies also didn't make a distinction between organized sports and what they called recreation or open, let's say, roughhousing or hiking. And so some of the key takeaways, that being said, include that sports generally account for less than 20% of ocular injuries. You can see the rate that they calculated here. And then the two studies where the rate was higher than 20%, children were the primary subjects, and they also included injuries from like general play or recreation. And this explains that increased percentage that I was talking about. And so I'd say in conclusion from this figure, quantifying the proportion of eye injuries that is attributable to sport is quite difficult for a variety of reasons. Next, the authors then tried to qualitatively compare the risk of injury across organized sports, and they cited this set of figures from Sports Medicine Illustrated, which essentially publishes an evaluation of risk based on the likely consequences rather than the incidence. And so, they just qualitatively compared different sports that involve, let's say, high-speed projectiles, such as air rifle and paintball, putting that into a high-risk category, as well as sports with fingers that come in close contact to the face, or hard and dense projectiles, such as badminton, tennis, squash, baseball, etc. They had this moderate risk group, which involves close physical contact as well as high-speed balls, and this included soccer, water polo, volleyball, etc. And then the low risk category here is often due to risks related to the environment, such as water or rain or dust or insects, cycling, swimming and diving, and rowing, etc. Yeah. The authors then reviewed the studies for distribution of injuries across the sports. And instead of discussing all the 30 sports they presented, I just want to provide some key highlights that I thought were interesting, or really highlight some key findings. So for example, soccer is generally considered moderate risk because the ball is much larger than the eye socket. But upon impact, it's known that the ball can have this rebound effect. Can create a knuckle effect, which can cause it to enter the orbit. And then when it is rebounding, it can create a suction effect. And that can further distort the eye and its structures. And as a result, there is a large amount of ocular injuries, especially in younger children, that is reflected in the data set. Squash is another sport that is well documented as having a risk of eye injury. And that makes sense because the ball is so small and moves at a very fast speed. And then this paper right here is a good time to discuss how, again, the rate of different sports being played makes it difficult to interpret data. And often the national sports are the ones that are most highly reflected in these studies. For example, Ireland is the only country whose studies actually reflect that hurling and Gaelic football are documented causes of eye injuries. And in contrast, in many European countries, such as Portugal, soccer is the most prevalent cause. And then in the US, basketball and baseball are well represented. On this page, again, badminton and tennis were also grouped along with squash. Again, these are small projectiles able to distort the orbit. And then again, seen in this one is how differences in distribution across the countries, again, is reflective of the rates of eye injuries. For example, softball is only reflected in the American studies, and baseball follows a similar distribution, whereas cricket, which is similar but played in the British Commonwealth, almost follows an opposite distribution. And so I think, now in conclusion, what this really highlights is how this literature review is actually very valuable, because it's not the individual studies that are useful, they're somewhat flawed, and the overall trend is rather more important when looking at the overall risk. And so now moving forward, cycling is one of the sports that's got the hazards related to the environment, such as the foreign bodies that impact the eye. And this can have an increased risk due to the increased speed of the participants. Golf is another sport that's interesting. For example, there was a spectator actually that was blinded during the Ryder Cup in 2018, I believe. The golf ball essentially struck them and caused a globe rupture and an orbital fracture. And then apparently using damaged golf balls, which apparently can explode, is another documented cause of eye injuries, as the particles can strike the eye. One thing I think was also interesting is how martial arts and boxing obviously are known to have high rates of injury, as is reflected here. But the authors went on to say that boxing, for example, is not of immediate interest in this review. And the reason why is because protective equipment is not a realistic option for these sports. And I'll discuss that when I'm discussing the design considerations in a couple of slides. Football is an interesting case in that because head and face protection is universal, injuries to the eye are at least not reflected in the literature super prevalently. And it's just interesting fact, apparently the penalty flag is a known ocular hazard. Okay, so now moving on to the prevention of ocular injuries, the authors wanted to highlight that protective equipment is essentially the last resort, the third step, and primary prevention of eye injuries is much more effective. And so now taking boxing and MMA as a key example, eye protection is thought to be impractical in these sports. One of the reasons is potential fogging due to the close contact between people, but there's also an inherent risk that is accepted within the sport. The authors go on to highlight how risk is an absolute fundamental of sport, the adrenaline rush of successfully overcoming their own fear for those that watch, the vicarious thrill of seeing risk accepted. And so, in these sports, primary prevention is done by modifying the processes, such as boxing gloves that are thumbless, and outlawing unacceptable processes, such as in MMA, eye poking being prohibited and being punished with a point deduction. And so in boxing, there are also minimal visual acuity requirements with required pre-participation evaluations. And some recommendations even ban monocular patients from competing in boxing MMA due to the inherent risk of blindness. So now moving on to the sports where eye protection is practical, many of the standards provided data replicating energy transfer and projectile size to support their recommendations, allowing each standard to be essentially sport specific. And some of the key takeaways include that energy transfer varies a lot between sports. For example, the environmental sports like skiing and swimming have a very low energy, sometimes less than 1 joule. And then some sports like ice hockey, baseball, and polo can create over 100 joules of force onto the eye. And the other thing to note here, sunglasses and basic occupational eye eye protection are not suitable because they can only resist up to like 1 joule of force. So not suitable for most sports. And so now moving on to the standards and the design considerations, coverage area is one of the recommendations that these standards provide. And some of the key highlights, some sports only recommended eye protection, such as in this case, field hockey. Others necessitate full head protection. Baseball and fencing is what's listed here. And I've included images of the headwear worn by these athletes. Baseball, I think, is another example of another reason why this is so complicated, because the specific hazards can be varied even within position within the same sport. So for example, you'd expect increased risk in a goalkeeper or a catcher in baseball, and that just makes quantifying the risk extremely difficult. One other major thing to note here, a lot of these standards actually fail to define the coverage area, and that was noted by the authors to be a major omission. Some more key principles, protective gear should not introduce new hazards. For example, let's say the eyewear breaks. You don't want that to become a foreign body that can then damage the eye, or you don't want decreased visibility, which can cause increased risk of injuries. And so these are also potential excuses for non-compliance that should be considered when balancing performance and safety in sport. And thus, these standards specify the amount of light that can get through, the luminous transmittance, as well as the field of view. And so, for example, when it comes to field of view, that might be limited with the equipment with a larger coverage area. So, for example, I've included an eye mask from a soccer player, which you might contrast with a football helmet that might provide less field of view. And field of view gets very granular, specified in the nasal, temporal, and superior and inferior directions. And then luminous transmittance is another one that is kind of balanced, as it's used to decrease glare, but it comes at the cost of decreasing visibility. So a balance is to be struck, and it kind of depends on the light exposure. So it's particularly important for the sports that are played outside, especially in snow where glare is a big problem. And related to outdoor sports, UV protection is another important consideration, but half of the standards actually fail to mention or require UV protection. And so for the sports that are indoors, you might think that, transparent eyewear would be an obvious solution, but that has its own limitations. Mainly, for example, when the eyewear actually has this wraparound effect, there's actually a natural visual distortion. Essentially, if you think about it, it's a concave lens, and that can cause, again, a visual distortion that needs to be repaired by the prism within the eyewear. And so the standards also include prismatic requirements in the eyewear. Okay, so in conclusion, sports eyewear standards vary widely, tailored to the specific hazards of each sport, and each sport has its own different risks according to energy transfer, and they also have various incidences, partially due to variation in sports being played across countries. Basic eyewear, such as sunglasses, is inadequate for sports due to low impact resistance. Many standards lack clear coverage guidelines, and this leads to gaps in protection. And other important characteristics often overlooked include optical performance, visibility, and transmittance, and UV eye protection. These are my references, and I think I'm pretty short on time, but happy to take any questions.
Hey, this is Dr. Troxler. A common board question you'll see is they'll ask in general in sports like basketball, what eye vision, if you're doing a vision screen, which ones do they recommend people wearing eyewear? And they want an actual number. I didn't see that information in the article. And so are you aware of any specific vision screening number where most sports?
I was looking I don't think that the article mentioned it actually, but
It
again,
didn't.
oh yeah, Netter's Sports Medicine I think mentioned specifically for especially boxing and MMA. I think that their visual acuity requirement was, I believe, 2040. I'm just kind of trying to remember off the top of my head. I'm not 100% sure, but I
Yep.
know that for that sport especially,
Yep.
it's
Yep. And so the sports medicine boards tries to classify people as monocular versus binocular. So if you have 20/20 vision and you're playing basketball, you probably don't need eyewear. But if one eye is 20 out of 40, they say that's a bad eye. You better wear eyewear. So just remember that 20 out of 40, and you'll get the question right every time.
okay. Thank you.
Well, thank you for that presentation. Dr. Kiel, anything else that you wanted to add that hasn't been discussed so far?
Sure, I can share a few thoughts. I know we are short on time, but good job, Ray. That was an awesome presentation. I would say, first off, nobody speaks ophthalmology except ophthalmologists. And so eye stuff is always tricky because it's just a different language, right? I mean, you're an ER doctor too, and every day they come and tell me something. I'm like, I literally don't know what you're talking about. So the preventative side of eye injuries, I think, is important to us. The other thing that I thought was interesting in this paper, I was kind of surprised, is they don't really talk about like environmental risk, like keratitis and uveitis from sunlight and ultraviolet rays. Did you, as you were doing some background research, did you find anything that discussed that in athletes, either risk or protective benefits?
Yeah, I mean, honestly not that much. Obviously, like the authors talk about how UV protection is important. As far as what I saw, I don't think they went into specific. Again, the authors don't do a good job of specifying like this type of protection is good for this type of eye disease. What I would imagine is that the UV protection would be good for a lot of those environmental like keratitis, etc. Um, to be honest, I'm not
Sure.
sure.
Yeah, there may not be a clear answer.
Thank you. There's so much. Well, Dr. Joe and Dr. Kiel, thank you so much for the presentation, for your comments. Really appreciate it. We'll keep going here with our second presentation. So moving on to our second presentation tonight, we're going to have Milan Patel and his club mentor, Dr. Desai. So Milan Patel is a second-year medical student at the Touro College of Osteopathic Medicine in Middleton, New York. His interest in sports medicine stemmed from his time as undergraduate sports medicine intern in the athletics department at Binghamton University for over 2 years, where he aided in the training room, providing assistance and rehabilitation exercises and providing sideline coverage for various sports. In his free time, Milan enjoys going to the gym and watching baseball and football. He will be presenting anterior cruciate ligament tear. And then Dr. Desai is an attending primary care sports medicine physician at the Children's National Hospital in Washington, D.C., providing care to adult and pediatric athletes across the D.C. metro area. He completed his residency in family medicine at the University of North Chicago, North Shore, and his fellowship at University Hospitals, Rainbow Babies, and Children's Hospital. He is the head team physician for 4 area high schools and collaborates with several gymnastics and performing arts institutions. Milan, please feel free to take it away.
So I'm presenting the article titled Anterior Cruciate Ligament Tear, and this was published in the New England Journal of Medicine in 2019. I'm Milan Patel, and I'm a second-year medical student, and my club mentor is Dr. Desai. So just to go over what to expect in this article, this article itself was a review article, and the purpose was to highlight the literature on ACL tears, such as the anatomy, the function, and mechanisms of injury. And then we're going to also talk about the clinical assessment and diagnosis, and then we'll finish it off with some treatment strategies and guidelines, as well as some additional imaging at the end. So why do we study ACL tears? What's the importance of it? So ACL tears represent more than 50% of knee injuries, with 40% of these tears actually being non-contact. It affects over 200,000 people in the US annually. The direct and indirect cost exceeds $7 billion annually. And young athletes who are competing at high levels every day are at an increased risk, and females especially are at a 3 times higher risk than males. Some common sports that you'll see these ACL tears in, especially for females, is soccer. They have a 1.1% of risk of tear per season. And then for males, it's football, where it's a 0.8% risk of tear per season. Additionally, ACL tears also come with a lot of different intra-articular pathologies. So you won't see an ACL tear just by itself. You might also see it with an MCL, an LCL injury, medial or lateral meniscus injury, even the posterior lateral corner, as well as additional osteochondral defects as well. So just to go a little bit into the anatomy of the ACL. So in the top left picture, the top red circle shows the origin, which is the medial aspect of the lateral femoral condyle. And then if you look at the bottom circle, that's the insertion at the intercondylar eminence on the tibia. So the function of the ACL is to stabilize the knee by preventing excess anterior tibial translation and limiting rotational knee movements. And now if you look at the bottom left picture, so this shows that the ACL actually has two bundles. The anterior medial bundle prevents excess anterior translation. And if you look at the picture, you can see that the anterior medial bundle is actually taut when the knee is in flexion. And the posterior lateral bundle, which prevents excess rotation and hyperextension, is actually taut in knee extension. So now we're going to go into some mechanisms of injury. And if you look at the image on the right, you can see that this is commonly coined the position of no return, with the femur internally rotated and the tibia externally rotated. So as I mentioned before, mechanisms of injury, non-contact is predominantly a higher rate. So if you look here, you can kind of split them into two different buckets. So direct contact would be considered valgus, where the patient has a physical blow to the lateral knee when the foot is planted. Or they could also have a direct blow to the front of the knee, causing a hyperextension ACL tear. And if you look at non-contact, there's a few more mechanisms of injury here. So this is commonly seen with pivoting, where the patient is planting and twisting. You could also see it with cutting, also with jumping, where the patient can jump and come down on a stiff leg. You could also see it again with hyperextension, but non-contact. Also with the axial compressive force, and then also with the valgus moment, which is also non-contact, where the knee, the patient could say it buckles. So let's say you're on the sideline. How would the patient present to you if they had an ACL tear? So they might come to you with a combination of the following symptoms. They might say that they heard a pop. They might say that they feel a tearing sensation. They might say that they feel swelling, and you might also notice an immediate onset of effusion. And you might also see that they might also tell you that the knee is giving out when they're bearing weight on it. So there could be a combination of these symptoms, and that can kind of clue you in that there might be something wrong with the ACL here. So just to go into some physical exam maneuvers here. So the first one we're going to start with is the anterior drawer test. So this is done by the provider stabilizing the affected foot, and they place the affected knee at 90 degrees of flexion. So they're going to stabilize the foot of the affected knee by sitting on it, and then you could place your thumbs on the tibial plateau and pull the tibia anteriorly. So here a positive test would be an increased anterior translation with a soft endpoint relative to the contralateral knee. And you could see here that the sensitivity and specificity of this test is fairly high. And now we can go into the Lockman test. So this is done by first placing the affected knee at about 30 degrees of flexion, and then you could externally rotate that leg. And then you want to stabilize the femur of that leg with one hand and pull the tibia anteriorly with the other hand. And a positive test here is similar to the anterior drawer, where you're going to feel that anterior translation, that increased anterior translation with a soft endpoint relative to the contralateral knee. And here you can see that the sensitivity and specificity are fairly high as well. And just to go a little bit deeper into the Lockman test, so you can grade the anterior translation from 1 to 3, where 1 is less than 5 millimeters of translation, and 3 being greater than 10 millimeters of translation. And you can also grade what the endpoint feels like from A and B. So if you grade the endpoint as A, that means it's a firm sudden endpoint, whereas if you grade it as B, it's a soft, ill-defined endpoint. And these are also some different variations of the Lockman test and how they can be performed. So if you look at the left, the stable Lockman test, this can be done if it's hard to kind of flex the patient's knee. So you can, the provider can place their thigh under the knee to induce the flexion instead of having this support with their hands. And if you look on the right, the prone Lockman test, this is also another way of inducing knee flexion if it might be harder for the provider to do it in the first way that I described. And lastly, the pivot shift test for examining the ACL. This is done by first placing the affected knee in a relaxed, extended position. And then the provider is going to want to place their one hand on the lateral aspect of the knee to induce a valgus torque and internal rotation. And then they're going to place their other hand on the inside of the ankle to induce axial compression and knee flexion to 30 degrees. So a positive test here would be feeling the sublux tibia reduced to its normal position as knee flexion is induced. So here you can actually see that the sensitivity is fairly low, but the specificity is very high for this test. Now we can go into some imaging of the ACL. So first you're going to want to get the x-rays so that can help identify a fracture, a dislocation, or a combination of both. But then the MRI is going to kind of help you see more of the meniscus and the articular cartilage and the collateral ligaments, as well as the ACL itself. So if you look at the panel of images on the right, the first image labeled A, that's just your normal ACL and the sagittal view. And if you look at B, that's your sagittal view of the ACL, but that's actually a torn ACL. And if you look at C, that's a coronal view of the ACL, and that's also torn. And if you look at D, the two arrows are pointing to bone bruising, and that's commonly seen in ACL tears as well. So now you confirm that you have an ACL tear. How do you go from here? So there's two different ways you can go. You can either go down the non-operative route, or you can go to immediate operation. Let's say you go down the non-operative route. You would do 6 to 12 weeks of therapy, and you would reevaluate at that time point to see if there's a need for a delayed operation to occur. If not, then you can go ahead and finish your non-operative therapy for about 3 months, and then you will be considered completed, and you would reevaluate again at the end. So what does non-operative therapy consist of? It's usually about 3 months of supervised PT with muscle strengthening, range of motion testing, and progressive return to activity. And then, like I mentioned before, you're going to want to reevaluate 6 to 12 weeks to consider the need for delayed ACL reconstruction. And this is just a panel of some of the exercises that you might see patients do during their non-operative therapy. So what might be some of the reasons that you go from non-operative therapy and transition to doing a delayed reconstruction? Well, this can be a variety of different factors. There might be persistent instability in that knee as you're doing rehab. There might also be a persistence of a fusion. There might be a new associated injury that comes up. And again, a lot of it depends on the patient demographics as well as their sport of choice. So these are all different factors that you want to consider when reevaluating the patient. So in the article, they looked at a variety of different studies. So looking at operative therapy, they analyzed a randomized control trial that compared ACL reconstruction within 10 weeks versus delayed reconstruction. And both of the groups had structured rehabilitation. The results that they found was that there was no statistically significant differences in the average scores on the knee injury and osteoarthritis outcome score. So they looked at subscales of pain, symptoms of instability, function in sport and recreation, as well as the knee-related quality of life. There's also no significant differences in the incidence of meniscus tears requiring surgery, and there's also no significant differences in the incidence of radiographically confirmed arthritis. The authors also looked at an observational study, and then that observational study found that the risk of a medial meniscus surgery or needing a medial meniscus surgery was 2 times higher when the ACL surgery was delayed for more than 5 months, but it jumped to even 6 times higher when ACL surgery was delayed for over 1 year. So just to see what the American Academy of Orthopedic Surgeons are looking at, they recommend doing 12 weeks of non-operative treatment. And then they recommend also reevaluating the need for surgery. And they said in the paper, they said that if surgery is indicated, it should be performed within 5 months of injury, which avoids recurrent instability and additional damage to the surrounding structures of the knee. So at the time that this paper was published, it was a 5 months, or they recommended it should be performed within 5 months, but updated guidelines showed that it should be actually done within 3 months instead of 5 months. And not to get too much into the weeds of the surgical procedures here, but I just wanted to point out that you could do a single or double bundle reconstruction, and the outcomes for both procedures are like fairly high and seem to be on par with each other. So there's it comes down to a case-by-case basis on what you might want to do for the patient, but both have shown good outcomes. So what are some surgical complications that might occur with ACL reconstruction? There might be a superficial wound infection that occurs. deep joint infection. You might also have some issues with the quadriceps after the ACL tear and doing a reconstruction. You could also have loss of motion if the graft was placed in the incorrect spot. And you could also have arthrofibrosis occur. So just to look at some of the different options for the grafts that you can take for the ACL reconstruction. So the semitendinosus, the gracilis and the patellar tendons can be used. And the authors showed that they have similar patient-reported outcomes and also similar rates of post-operative osteoarthritis. Typically, since the patellar is bone to bone, it's generally stronger, so it's preferred for high risk of re-tears. In terms of the quadriceps tendon, a pro of this is that there's less damage at the site of harvest compared to the patellar tendon. And if you look at the autograft of using the iliotibial band, this is common in pediatric population with open physes that are skeletally immature. And allografts, they're typically not preferred, one, because they have higher costs, but also they have higher rates of graft failure and higher rates of ACL repeat tears. The only time it would be preferred is if the patient does not have a viable autograft. So as I mentioned at the beginning of the presentation, concomitant injuries is fairly common with ACL injuries. So the authors showed that meniscal injuries, there's 26 to 45% of patients that experience ACL tears also have a meniscal injury with it. And it's indicated that meniscal repair at the time of the ACL repair is associated with positive outcomes. Now, if we shift over to the collateral ligament injuries, such as the medial collateral ligament and the lateral collateral ligament, this is seen in 19 to 38% of patients who also had an ACL tear. And management here is determined on a case-by-case basis, except if you have a grade 3 injury, which is a complete tear, that often requires surgery. So to kind of summarize that multiple ligamentous injuries, the best thing to do is to see what types of injuries it is, and observational evidence suggests that early surgical management of all damaged ligaments has positive outcomes. So after surgery, post-operative rehabilitation, it follows a similar layout to non-operative therapy. So it usually starts the first week after surgery and it continues for about 9 months. And this usually consists of 2 to 3 sessions per week where patients are coming in and going through a variety of different exercises and therapy. So you have cryotherapy, you have quadricep strengthening, hamstring exercises, closed and open kinetic chain exercises, as well as the neuromuscular and agility training, as well as exercises to strengthen movement patterns that opposed to those that can injure the ACL. So that could be another way to prevent future re-tears. So the authors talked a lot about the Tegner activity level scale, and I put a little image of it on the right here. So the goal for all these patients is to return to the same level of play, which is the Tegner activity level. But the truth is that only 40 to 55% actually return to the same Tegner activity level after the ACL surgery. And it was found that the average return to play was actually 2 Tegner activity levels below the level before their injury. So when it comes to the return to play, the timeline, it's about 9 months from surgery, but it also depends on the player's ability to meet return to play criteria. So some of the return to play criteria include symmetric quadricep strength, symmetric performance in the hop test, as well as a ideal quad to hop hamstring ratio, and also proper hip strength. And this is an image of the hop test on the right, where you do the single hop test, the 6-meter hop test, a triple hop for distance, and a crossover hop test. So in terms of re-injury rates, it was about 4.5% in those who met the criteria to return to play, but it was actually 33% of re-tear in those that did not meet the criteria to return to play. So that's a huge jump from the 4.5% to 33%. Re-injury rates was also higher in those who returned before the 9-month mark. And there was also an associated lower rate of return to pre-injury Tegner levels in those who had negative psychological responses. So I put a couple of images on the right here of some of the different forms that clinicians can use to assess a patient's psychological readiness to return to their sport. Because as we know, ACL tears, although they are a physical problem, there's a lot of psychological trauma that can go on and that can prevent a patient from returning. So it's very important to I address this. So in terms of ACL injury prevention, the authors mentioned bracing, and they looked at a randomized control trial with football exposures and using a brace showed a significant reduction in overall knee injuries. They also looked at preventative training programs, and they analyzed meta-analyses where the preventative training programs focused on sport-specific training, biomechanics, and proprioception, which all showed to have a big factor in significantly reducing the per-season risk of ACL injury. To kind of wrap it up, some areas of uncertainty. There needs to be more data on whether you do initial surgery with rehab, followed by rehab versus initial rehab with delayed surgery. We also need more data on the management of concomitant injuries. And as we know in sports medicine, PRP and stem cell therapy has gained a lot of traction, and rightfully so. So there also just needs to be a lot more research done specifically for ACL tears in this area as well, before we can come out with guidelines on what to specifically do in all cases. And another thing that was mentioned was, or that we talked about, was the bridge enhanced ACL repair, also abbreviated as BEAR, which was an FDA-approved surgical reconstruction technique. I think it was approved in about 2020, so fairly new. I put an image of it here on the bottom right. I don't want to talk too much about it, but if you're interested, I know that the AMSSM National Fellows Series had a YouTube video on it about a month ago, and they mentioned the BEAR technique, so I recommend checking that out. So now we're just going to go into a few images here to kind of reinforce what imaging would look like in an ACL tear. So right here, the red arrow is pointing to T2 fat suppressed sagittal ACL tear.
Milan, and I think maybe let's go through maybe one or two more, and then after that, let's close it up for discussion.
Sounds good. Thank you. And here is a bone bruise and a contusion that we looked at before. This is a popliteal cyst. And this is a sagittal ACL tear with a fusion with a yellow arrow pointing to it. And this is a Sagan fracture of the tibial plateau. These are my references. Thank you.
Having seen hundreds of ACL tears, especially isolated, I hate to say the physical exam is not as black and white as the article may seem. In most articles that I've read, sensitivity of Lockman and drawer is about 60%. So you have 100 patients with ACL tears, your exam, you're going to find 60. And the other 40, they're going to be normal. And so this is a common question. What do you do next? You know, if you have a moderate suspicion, your exam's normal. Specificity of the exam is terrible. It's 50%. So where do you go from there? I mean, you don't want to miss an ACL tear.
I think I'll step in and help Milan out here a little bit. I mean, certainly that's a very common clinical scenario, as you obviously have seen in your practice also, Dr. Troxler. So in those cases, especially if your clinical suspicion is low and your physical exam doesn't match it, I typically will start them on at least a guided physical therapy protocol, see what they look like, have them come back, do a reevaluation. And often that second visit is then when you can detect it. So if you don't have enough to make the call to get an MRI based on mechanism, based on physical exam, based on current exam presentation, that's typically been my approach.
Yeah, I think another just add in there as well. I think, you know, certainly if you have an acute effusion with some potential mechanism, I think that's another clue that would at least make me consider that highly. So I think that's something else to think about. If you have an acute effusion, you need to explain that somehow. And so if it's not a ligament injury, it's something else. So at the very least, that might be something that would prompt imaging in and of itself. Any other questions from the audience here? Or Dr. Desai, any other input you wanted to provide that we haven't discussed so far?
Yeah, I think just a couple real quick things. You know, one thing that I had heard from different attendings throughout my training when I was a med student and resident was pediatric patients, like those with skeletally immature open physes, shouldn't get ACL reconstructions. That was a commonly held belief for a long period of time. And I think there are certainly risks to a surgeon who doesn't have that in their skill set to do it, but there are actually widely accepted, very effective surgical techniques for those patients. So if the surgeon in your practice doesn't have comfort with it or doesn't have it, you know, make sure you know who that person in your community is, because you may be, like Milan said, you may be opening them up to secondary injuries if they keep trying physical activity or having instability events until they reach skeletal maturity.
Yeah. Yeah, I think that those are great points. And I think something else, I know Milan, I know you talked about the role of non-operative management here, and I think I think that there's some data, there's like some bracing protocols that have been reported in the literature, and there's different components that you highlighted. I think there's a lot of caveats that go into that, and so I don't know that it's as simple as try non-operative approach and then go on to surgical approach thereafter. I think there's a lot of considerations that go into that. And then I think one last thing would just be that I know you talked about biologics at the end there. I think one thing is just making sure that we're kind of using the appropriate terminologies. I probably wouldn't use the word stem cell. We know that term is not necessarily correct, and so I'd probably use mesenchymal stromal cells or cell-based therapies as well. But anything else from the audience that wanted to comment on here? Okay. Well, great. Well, thank you both for that. That was fantastic. Certainly a very important topic in sports medicine. Well, we're going to go on to our final article here. And so I'm going to introduce Dr. Patel. He's a second-year internal medicine resident in Georgia with the aspiration of pursuing a sports medicine fellowship. He's passionate about promoting wellness and optimizing performance. Dr. Patel has been actively involved in community health initiatives and in his free time, creating educational content on various sports medicine topics. Outside of medicine, he loves traveling, playing basketball, and learning the piano. He'll be presenting on the cost effectiveness of pre-participation physical screening for prevention of sudden cardiac death in young athletes. Dr. Chu, the club mentor, is an associate professor at the University of Louisville, and he is triple board certified in internal medicine, pediatrics, and sports medicine. He serves as a team physician for various athletic teams, including collegiate women's soccer, volleyball, and baseball. Dr. Chu is a strong advocate for training involvement in AMSSM and previously served as the pediatric representative for the AMSSM SMRC, and he was the 23-24 fellowship class representative to the fellowship community. He completed medical school at Wright State University in Dayton, Ohio, and then completed his internal medicine and pediatrics residency and sports medicine fellowship at the University of Louisville. Outside of medicine, he enjoys spending time outdoors with his wife and 2 children. Dr. Patel, please take it away.
Hey guys, I don't know if you could hear me. See my screen here. Yeah, the name of the title is Cost Effectiveness of Pre-Participation Screening for Prevention of Sudden Cardiac Death in Young Athletes. Try to say that 3 times fast. I want to say thanks, Dr. Justin Chu, for taking the time to moderate tonight for the guidance, and I'm going to get the ball rolling here. It's a number-heavy article, so I'll try to break it down as best as I can and hopefully have time for questions after. All right, so sudden cardiac death, as we know, is one of the leading causes of young athletes. In the U.S., 80% of the cases are male athletes. Not to say that female athletes aren't affected, but it's predominantly seen in males, with hypertrophic cardiomyopathy being the most common underlying cause, accounting for 36% of the cases in young athletes. So with that being said, the most common cause of death in young athletes is particularly those engaged in strenuous physical activity. There's a study back in 2006 involving collegiate athletes that showed case by case the etiologies of sudden cardiac death, with, by the numbers you could see here, predominantly being hypertrophic cardiomyopathy in white and non-white athletes. In terms of other etiologies we keep in mind here, arrhythmogenic right ventricular cardiomyopathy, which is essentially when the fatty tissue is replacing the tissue in the heart. That could lead to abnormalities in the conduction from the SA node, leading to fatal arrhythmias. There's also other less commonly seen things, but also prevalent in sports. Comatio cordis, which is a sudden traumatic force to the chest wall that leads to, again, fatal arrhythmias. In terms of prevention of adverse events, it really does come down to various roles here, whether it be sports medicine, emergency medicine, cardiologists, sports cardiologists, counselors, primary care, all coming down to a multidisciplinary approach. That really does help kind of key in to the role of the importance of kind of a shared decision-making process when it comes to detecting sudden cardiac death. It really does come down to having this open discussion with the athlete, the family, and a multitude of players involved. In terms of Pre-participation screening components, we look at the HNP, of course, a focused HNP, EKG if needed, and case by case. I'll go into the kind of the guidelines with the American Heart Association and how that compares to the European Society of Cardiology and their recommendations here. But there's been this growing adoption of screening, especially from a study that was done in Italy in the 1980s that kind of looked at the incorporation of an EKG as the standard for pre-participation screening. And what they found was the incidence of sudden cardiac death over a 10-year course dropped from 1 in 200,000 to 1 in 300,000 athletes, just kind of supporting the shift in paradigm in the need of potentially having more screening interventions or a different type of screening intervention involved beyond the standard of a focused HNP alone. In terms of screening effectiveness here, it's important to keep in mind most conditions implicated with sudden cardiac death do not have an initial physical sign or symptom that an athlete will present with. So a lot of the times these athletes are flying under the radar, not knowing that they have these kind of abnormalities, whether it be in their heart or genetic predispositions that may lead to these events. So it's important to kind of keep in mind, that there may be more screening that needs to be done to detect these events from occurring. In terms of the guidelines, AHA and European Sports Society of Cardiology, are evolving to better balance the screening strategies, like I mentioned before. But there are challenges associated with the guidelines, of course. In trying to implement a universal screening comes at a cost. Also, potential false positives that could lead to unnecessary testing from some specialists that may or may not be needed if an athlete truly doesn't need additional testing. In terms of the American Heart Association and their guidelines, with the focus on a focused history and physical, it's pragmatic in that, it's very focused to the athlete. However, the sensitivity is poor. Like I mentioned before, about 80 to 90% of athletes that are walking through the door don't present with symptoms on their initial presentation. This could lead to higher false positive rates in the inexperienced hands in evaluations, thus leading to unnecessary investigations that may be commonly seen symptoms in these training athletes. And on the right, I just put in kind of pathologic findings you'd see on EKG that would be more alarming if an athlete did present and an EKG was done that kind of depicts hypertrophic cardiomyopathy. Some things you look for: inferior or lateral wall T-wave inversions, ST segment depressions, pathologic Q waves, and arrhythmogenic right ventricular cardiomyopathy. 40 to 50% have anterior T-wave inversion in V2 to V4, epsilon waves. In terms of current recommendations, like I mentioned, the AHA recommends a detailed personal and family history. European Society of Cardiology, which is endorsed by the International Olympic Committee and several other professional organizations, do include that 12-lead EKG in addition to screening history and physical examination. And it's reported that EKG screening can detect approximately 95% of those with hypertrophic cardiomyopathy and 80% with ARVC. In terms of the concerns I touched on before, the large population of athletes that need to be screened in the US, 10 to 12 million, high false positive and false negative rates. For example, what is defined as normal and abnormal in an individual study really does come down to the patient population, demographics, otherwise. Liabilities has to be taken into concern. Sometimes physicians have the sole responsibility to disqualify athletes from competition and enforce these pretty heavy decisions. Lastly, cost effectiveness, of course, startup costs, resources, additional testing costs like echoes and stress testing. In terms of the false positive rate, I just included this EKG. It has multiple abnormalities, as we could see here, with the right axis deviation, incomplete right bundle branch block, sinus bradycardia, as well as left ventricular hypertrophy, which in a training athlete, you could typically see in all cases, but they are more commonly seen in these type of athletes. And here I just included just more of the uncommon findings you've seen in EKG, such as T-wave inversions, left atrial enlargement, and complete blocks. EKGs in athletes typically present with like vagotonia. They could have bradycardia, like I mentioned before. LVH is commonly seen. Incomplete blocks are also sometimes seen too. In terms of the role of screening in sports recently, there's a couple athletes that did have sudden cardiac arrest. One of them was Bronny James, the other was Damar Hamlin, both in different ways. It was commotio cordis, I believe, for Damar, and eventually this kind of speaks to the point that, you know, sometimes there are warning signs, but more often than not, they're not. There's no symptoms that the patient will present with, so it kind of speaks to the importance of the need of thinking of other ways to screen athletes to prevent such things from happening. In terms of cost screening versus cost of sudden cardiac death prevention, you know, while the cost of implementing this universal screen is high, the potential savings in lives saved and the prevention of economic burden associated with sudden cardiac death makes the case for cost-effective screening more compelling. And that's where this article kind of ties in. The goal of this article, essentially the objective was to evaluate the cost effectiveness of various cardiovascular screenings. They used 3 branches with no screening group, a history physical exam only group, and a history and physical with an EKG group for prevention of sudden cardiac death in young competitive athletes. What they found was adding an EKG in pre-participation screening overall saved 2.06 life years for every 1,000 athletes that were assessed. In terms of the overall findings, the EKG compared to the standard screening, which was just a normal history and physical exam that was focused, showed that it does provide more benefits, though at a cost. A little bit more about the intro from the study. You know, there's been an increasing rate of sudden cardiac death in young athletes. At least 90 athletes a year are affected, and that brings the question, you know, why the importance of having this screening take place. And a lot of the reasoning comes down to the level of intensity that athletes are playing at nowadays, you know, with the increase in demand, the increasing dynamic of the sport, requires more from the athlete, putting them at higher risk of such events for occurring, and brings to the need to take action to prevent such adverse events from happening. In terms of a little bit more of the background, autopsy proven cardiac abnormalities have helped diagnose sudden cardiac death. It just brings into question the debate of role of screening needs. Italy already has this kind of structured use of the EKG in their screening, and this study tries to kind of emulate the model, the cost effectiveness of an EKG as part of a routine screening. And in the study from Italy, the pre-participation physical is governed by the decree of Italian Ministry of Health, which does require physicians to essentially incorporate the EKG in their H&P. And now it's been over 30 years in which they've been kind of adhering to that practice. And what they've seen is 89% absolute risk reduction in sudden cardiac death for competitive athletes. So this study basically seeks to model the cost effectiveness of including that 12-lead EKG as part of young athlete pre-participation cardiovascular screening. So the population being tested was young athletes, aged 12 to 22, both male and female. They used this thing called a decision model, which I'll talk about in just a moment. And the decision model kind of uses what they call the Markov model structure. Essentially, there's 4 possible outcomes, and they would follow the athlete from various health states, whether it be no disease, disease detected, to sudden cardiac death. And they base it on the accuracy of the screening with, you know, true positives, false positives, true negatives, and false negatives, and then modeled the outcomes of the athlete over a long-term assessment for incidence of sudden cardiac death. The perspective was societal, including cost from, you know, healthcare, time it takes to get to the office. They essentially took the Italian study that I mentioned earlier and applied that data to US essentially. And I'll speak on that just in a little bit. There's 3 screening strategies that they used. There was a no screening strategy, a cardiovascular disease focused history and physical alone based off the recommended AHA panel. And lastly, they also had the cardiovascular disease focused H&P with a 12-lead EKG as recommended by the European Society of Cardiology. Here we have our first figure, basically in a nutshell, was showing our 3 branches. They used test characteristics for the H&P, which included a range of assumptions for the test characteristics for the H&P and EKG that were evaluated to account for significant variability in the reported sensitivity and specificity for the undiagnosed cardiac disease in athletes. They essentially used the study from Italy to derive data from this study and for this study here. They had a true positive group that were confirmed to have any abnormalities and would require further testing like an echo or a stress test. If they tested negative, they were either placed in the true negative or false negative group from there. And the positive group was those who truly had the disease. Persons in the positive testing branch were subjected to that secondary testing like I mentioned. And here we have a table, the table one that was on the other page continued essentially. What they found was the cost of screening includes the direct cost of the test, which was $73 for the physical history and physical exam, and the EKG of $34, as well as any secondary testing costs that they had. And they basically had baseline cost obtained from the National Center for Health Statistics data, and they kind of tracked that along through the study to get their overall figures. In terms of rates of sudden cardiac death in athletes and non-athletes, they were calculated using data from the study on pre-participation athletic screening that was conducted in Italy. These rates were then applied to the US population by estimating the prevalence of the predisposing cardiac disease factors in the US. And from there, they were able to derive the incidence of sudden cardiac death in athletes. They also took into account the prevalence of sudden cardiac death in the US versus Italy. For example, in Italy, they were a higher prevalence to have arrhythmogenic right ventricular cardiomyopathy versus the US, which was more higher frequency number of premature coronary artery disease and hypertrophic cardiomyopathy. In terms of the screening, just to break it down, the key takeaway was the history physical plus the EKG group had the most life-saving benefit, but it did come at a higher cost. In terms of the validation of the model predictions about sudden cardiac death and healthcare costs were compared to the real data, like the study on athlete screening in Italy. And in terms of accuracy, the model's results were very close to the actual data, showing that the EKG was a good tool for assessing screening strategies in young athletes. In terms of evaluation of screening modalities versus no screening, what they found was in the groups head-to-head of a screen population of 3.7 million competitive athletes, about 107,000 athletes were recommended to go additional secondary testing. And from there, they were found to have an incremental cost of 410 million. And this was in the group that was just focused on the history and physical. In comparison to the history and physical group with the EKG, led to 2.6 life years per 1,000 athletes that had lives saved. However, the cost was incrementally higher at $737 million in comparison. So in a nutshell, I guess, H&P was shown to be better than no screening, but the EKG history and physical exam had the best outcomes in terms of life years saved, though it was less cost effective. In terms of table 2 here, I included the key takeaways here. It kind of focused on more of the years of life gained. And here we see the history and physical and the EKG strategy saving the most lives compared to the no screening, with an increased life year saved from 0.5 to 3 per every 100,000 athletes that were assessed. And in terms of cost effectiveness, both the history, physical exam, and EKG strategies have similar cost effective ratios of $66,666 per life year saved. This basically was suggesting that the EKG screening adds significant costs. It also provides this substantial benefit in terms of life saved. In terms of addition to EKG and to the history and physical exam, just reiterates that though more expensive, adding EKG to the H&P remains the most cost kind of beneficial option when considering the long-term benefits in life years saved that were shown. They used also a one-way sensitivity analysis, basically to show how changes in one factor like cost of or effectiveness of the study could affect the overall results of the study. For example, the model might check how effective EKG screening changes if it costed lower or higher. This kind of helped to conclude whether or not EKG was being the best option still holds under different conditions. Other than that, what they found was the cost effectiveness frontier illustrated that while the EKG screening is the most costly, it also is the most effective in preventing sudden cardiac death, making it the preferred strategy for high risk athletes when healthcare resources are available. In terms of the probabilistic analysis, they used a one-way sensitivity analysis, looking through 10,000 different simulations, and found that the EKG plus the history and physical exam costs less than $100,000 per life year saved in about 80% of simulations. In contrast, the history and physical alone cost more than $100,000 per life year saved in all of the 10,000 simulations that they were assessing. And overall, just showed that the addition of an EKG was incrementally more life-saving in mainly all the simulations versus just doing a history and physical exam alone when doing our pre-screening assessments. Here's just a graphic representation of their testing that they did with the simulations. In short, basically, this figure helps us kind of understand how the small changes in the assumptions made through that one-way analysis about the cost or test effectiveness can impact the overall decision making when it comes to the best screening method that should be taken. In terms of cost effectiveness of other screening modalities, they also talked about the cost effectiveness of other potential screening modalities that could be used, such as echoes and MRI were considered, but these were more expensive and less widely applicable than an EKG as a screening tool method. Other than that, in terms of discussions, what they found was the EKG screening is the most effective for preventing sudden cardiac death in young athletes, though it did come at a higher cost. History and physical exams were cheaper but less effective, and cost effectiveness varies based on prevalence of the heart disease in the population being screened and the cost of the EKG. And despite the concerns over the total cost, the incremental life years saved by including EKGs were quite significant from their study. Essentially, to combat the cost, they organized mass screenings of young athletes were recommended to improve the efficacy of potential cardiovascular screening and improve overall cost effectiveness. Long-term effects of early diagnosis and treatment of high-risk diseases like hypertension and hyperlipidemia weren't really taken into account and evaluated, which may have obscured potential data. Otherwise, overall sensitivity analysis showed that nearly all the cases here, screening with the EKG routinely with a history and physical exam is the preferred strategy. Some limitations in data that they included, relying on existing data that was used from the Italian study that was done many, many years ago, making assumptions.
And Dr. Patel, just letting you know, probably about 30 seconds left maybe here.
Okay, I'm on my last slide, but yeah, thank you. And then other than that, I guess generalizability, this model based in the U.S. healthcare system, which may not, which may differ in countries in different healthcare systems. And in conclusion, despite the higher cost of EKG, it is a valuable investment for long-term health benefits, including preventing sudden cardiac death, though it's not the standard in the US at this time. And some key takeaways I mentioned before, and that's pretty much references here.
And Dr. Chu, any other input you had or anything else you wanted to add that's beyond what's been discussed?
Yeah, I'll just say something real quick. Dr. Patel, first off, great job. Well done. That was a dense article, a lot of information, but my only main points to like final takeaways. I don't know how much this is like practice changing, because a lot of this, like you said, like in an ideal world, if you get EKGs on all these athletes and resources like not permitted, like, yeah, it's great. You can save a lot more lives. But I guess the thing I think I would encourage the most for like trainees would be to be comfortable with a lot of the abnormal EKGs that you can see that are normal in athletes. So just kind of be cognizant of that too, just because of reading those would be misleading if you're not in the appropriate setting. But great job. Well done.
Yeah, thank you. I think it was a very number heavy article, but I'm glad we got some takeaways from it.
Yeah, absolutely. Absolutely. Yeah, I think that's a fantastic point. I completely agree that I think that's a really important thing to emphasize there. So, well, we're at the end of our presentations now. So I want to thank each of our presenters as well as each of our club mentors for their time and for all of their input tonight. This was certainly a great discussion. I want to welcome everybody for our next journal club. The next one will be on Tuesday, February 25th at 8:30 p.m. Eastern Time, and I hope that you all join us. At this time, that'll conclude tonight's journal club.